after they undergo nephrectomy. Obviously, the historical standard has been observation. Not going to belabor the number of adjuvant studies of interferon, interleukin, other mouse products, etc. They've all basically fallen by the wayside. But we do know that last year there was an FDA approval of sunitinib in the adjuvant setting. So these are the 3 studies that are in the targeted era. I'm not going to belabor the first 2. We all know them. I was going to have to spend a little bit more time talking about S-track. Those of you who are aficionados understand the issues about patient selection, dose modification. But the good news is, we're going to get to the good news. Well, good news, bad news, depending on perspective. This is toxicity. Naomi Haas gave a nice talk about adjuvant therapy at ASCO GU, and she pointed out and reminded us about the therapy burden of these agents, which is hard enough in patients with metastatic disease, let alone for patients who are receiving therapy in the adjuvant setting. So this was in the public domain within the last 2 weeks regarding the adjuvant axitinib trial, which was a study of increased duration in the adjuvant setting. So I think, to be honest with you, it becomes a much shorter talk about targeted therapies, although this study has not been presented yet. Should it be a negative study in the way the first 2 studies? I think that at some point in time, one has to think that the preponderance of evidence, taken into context that S-track was a very mature study without a survival benefit, that perhaps short of additional data, I think this may seal the sort of the controversy. These are ongoing targeted studies that have yet to report, including another sort of longer duration sorafenib study done in the UK by the MRC, and the US intergroup Everest study is yet to report. There are obviously lots of ongoing adjuvant studies in the IO setting, and this is just a selection of some of these studies. Likely to be some long-term follow-up required before we see data here. Some of these trials are still accruing, obviously. So is there a role for adjuvant therapy for patients with high-risk renal cancer with regards to targeted therapies? My answer is currently no, based on the preponderance of evidence. I remind my fellows all the time that random things happen, including in randomized studies, and sometimes you just have to understand that. There is the therapy burden of the treatments that we know come from TKIs. We will see some other targeted study results in the relative near term. Obviously, should those studies be positive, I think we have to reevaluate. Should they be negative, I think it would seal that question. Next generation IO studies are ongoing. My sense is the standard of care for high-risk patients, it requires clinical trial enrollment. That's the way we need to move forward. And that's it.
So now, again, as we've kind of seen what happened with the TKIs, the one little bright spot and then everything else.
Well, I don't know about bright. It was like a little bit of a...
Okay, well, a little shining of the window. Maybe dawn was coming, maybe not. But from that standpoint, though, now we have a ton of stuff, and reasonably so. We're excited about it, immunotherapies through the immune checkpoints. But now we're doing a lot of trials. Is this the right thing? I mean, should we be going in both guns blazing with multiple different trials with this, or do we just, I know it's different companies, but, do you think, in your opinion, are we going in too fast, too hard with these therapies, and we should take it more steps? Let's get a positive trial first, and then start saying how better to do it and what to add to it.
Obviously, if Oliver Sartor ruled the world, we would do things in a different way, right? But
no.
I think at the
he
end,
would have voted for Trump.
I think the reality is that, as you point out,
we would do things differently.
These are hard studies to do. I think the key is, it would be nice to be able to just do a couple of studies and get an answer. But the reality is, it's not the world we live in. And the world we live in means that folks that have drugs, that have activity in advanced disease, who want to study to look for a new indication, because it's not a small subset of patients when you start talking about worldwide. And the potential is if an adjuvant study with a well-tolerated potential therapy changed the natural history of the disease, it would be a real big deal. So, yes, I would like there to be fewer trials and get answers, but I think the key is just to get these patients on trial and finish them.
So my next question along there is that, so there's a lot of different trials different. You know, we have the Kentucky Derby today, and they weight the probability of winners. If you had to, you know, not say which one will win or not, but if you had to rank them, is there studies that you kind of say, I'd rank this as a, you know, as the favorite coming into this, or are they pretty much all equal? And it's a what's your opinion?
So here, I'm going to tell you just a little anecdote, which I think will answer your question. So I learned, well, my fellows remind me very frequently how much I don't know about stuff. I was sitting at the table when Charted was designed. Okay, I'm a co-author of the paper, and I was very supportive. We enrolled a lot of patients. But I damn well was absolutely convinced there was zero chance that trial was going to be positive. So every time I think I know anything, I remind myself the reason we do randomized trials is because if we knew the answer, we wouldn't do the study. So my answer to you is I do not know.
Thank you.
Thank you.